Thank you. Sorry about that. I'm good. And you, Dr. Andrews?
I'm doing very well. Thank you for having me on.
We are very excited about this setting that we have today and the interview that we have today. We really want to highlight the fact that mental health professionals are on the front line, right? And I don't know if that's done enough in our community, in our culture. We hear a lot about nurses and doctors, and of course, they're doing a great job. But what about the mental health professionals? What do you think about that?
Well, I think it's really important, Kenya, that we highlight this right from the beginning of the COVID crisis. Although the behavioral health practitioners were finding ways to make sure they could continue to provide services and to make sure that there's no gaps in coverage and to do that safely. I think that we do have some advantages over the healthcare providers and some of the other essential workers is that we can do a lot of work remotely, right?
Mm-hmm,
And
mm-hmm.
so one of the things that, and there's a couple of things going on we need to recognize. There are some behavioral health professionals that are still doing face-to-face services. They're doing that using PPE and following all the guidelines, and that's really great. But we also recognize that we wanted to reduce risk of exposure for our staff and for clients and for other facility members.
Yeah.
So BHR worked really quickly in the first couple of weeks of the crisis to move our services to remote, right?
Yeah.
So, and that was a big transition for BHR because we were used to doing remote work. It was still a lot of work, but we were really comfortable with it. Whereas a lot of other providers have had to switch gears and start doing phone work and telehealth work that they'd never done before. So there's been a lot of transition in this process.
Yeah.
It's really important that we recognize that for most healthcare workers, they didn't stop working when this crisis started. They've been plugging away and making sure that people are getting the services that they need.
That's right. I agree. Do you think the recognition is good enough of the mental health workers and the hard work that they're putting in to get our clients through such a difficult time?
No, not at all. I think internally, I think the agencies have been incredibly good at recognizing their staff and all their staff have been doing.
Mm-hmm.
But one of the dirty little secrets of our culture is that we don't value behavioral health care as much as we should, or behavioral health care providers as much as we should. And this is one of the things that's really important, that we recognize how hard folks are working and what a vital role behavioral health care professionals have in ensuring safety, in helping
Mm-hmm.
people stay healthy, and making sure that folks are able to function and go about their lives during this really difficult time.
You're absolutely right. Absolutely right. Thank you. I feel like we should get more recognition of what's going on. And I think that will help get the word out that services are still available. I think some people thought because of COVID that our services would decline or the services wouldn't be as readily available. But because we have made such great strides and transitions, we are still available. We are still here 24/7. And I think that's very important for people to know.
It's really important. Now, what's really interesting is BHR has been tracking this really closely, and in March, everything stayed kind of level. We did see a decrease in our number of mobile outreaches, which is, so for folks that don't know, we send clinicians out into the community 24/7, wherever the mental health crisis is. And those did drop, but that's not surprising because people were starting to hunker down, and there was a lot of concern about people being infected or getting exposed, and also activity slows down. One of the things that people don't realize is a lot of our referrals are generated by schools and other agency staff. So as agencies shut down, some of our referrals slowed down a little bit.
Yeah.
But what's really interesting about this is we started tracking COVID-related calls right away, and we always track suicide. And we noticed that April, we actually had about a 15% increase in call volume. And now what's really interesting is that by mid-April, almost 50% of our calls were concerns about the COVID crisis. So there was a tremendous amount of anxiety and very, very valid concerns about what was going on in people's lives and how COVID was impacting them. At the same time, we saw a decrease in the percentage of calls that were suicide related. In fact, suicide related calls plummeted compared to March and compared to April of 2019. And what's really interesting about this is that as COVID-related concerns started dropping towards the end of April, the number of people calling about suicide and acute mental health crises started increasing, right? So you kind of saw this part where everybody kind of was focused on COVID and everybody was hunkered down and just kind of figuring out how to survive.
Mhm.
And then as things started to ease a little bit, as we start hitting into May, as life starts returning a little bit more to normal, then all of a sudden people have a little more safety. And what's really interesting is that's when you start seeing some of these things bubble up and things getting harder for folks. Everybody thinks it's harder in the middle of a crisis, and that's sometimes true. But a lot of times things are a lot worse when the crisis starts to resolve itself, and that's when things can get really bad. And that's what we're anticipating.
You're right. You're absolutely right. Those are really good statistics and information about how suicide is impacted by this crisis and this pandemic that is going on. What do you expect to see? What trends do you expect to see based off of the information that we have now? Do we expect to see suicide rates to go up after this is over? Do we expect that we will need more care for individuals after this is over, since it just might increase after we get through this?
It's a really complicated cluster of events that we have hitting all at the same time. So it's really hard to predict the future. And a lot of it depends on how the community responds.
Mm-hmm,
And
mm-hmm,
so some things that we know is that, one, human beings are amazingly resilient. And in fact, the idea that when a crisis hits that human beings automatically go into crisis and fall apart, the data suggests that's the exact opposite. That in fact, when a community crisis hits, people tend to rally and they pull together coping resources and they survive. So I'm always really concerned. There's a lot of media out there. Oh, this is a mental health crisis. Well, for some folks it is. A lot of folks are just doing what they need to do to survive and take care of themselves and their families and their community, and they're rallying, right? And the
yeah,
data,
yeah.
yeah, the historical data shows that that's actually the case. But we do know that there are other things going on that could definitely impact the emotional impact, the rate of experiencing symptoms of mental illness and suicide, financial crises and unemployment and housing, right? So if we don't act aggressively to make sure that people have money, food,
Mm-hmm,
a place to
mm-hmm,
live, and job opportunities, if
mm-hmm.
that goes on for an extended period of time, it will likely cause an increase in lots of things, right?
Wow.
It'll cause an increase in people being unhoused. It'll cause an increase in people feeling stressed and hopeless, and that typically leads chronic unemployment, chronic financial problems. Typically leads to an increase in the suicide rate. So how we respond to this crisis will have a big impact on what sort of a response we get 2 months, 3 months, 4 months down the road, right? So if we see that, for instance, if there's good financial support, if we make sure people are getting their unemployment, or we keep giving folks money to survive while they're looking for work, that sort of thing, if we're making sure that their basic needs are met and we're addressing the housing issue, I would expect that we might see a little increase that we should be able to manage. But if we don't do those things, if this is prolonged, or if the recovery is prolonged, if, for instance, when we open things back up, if everybody isn't able to get back to work right away, that's going to be a really big problem. We
Absolutely.
Yep, we saw this in 2008 following the
Mm-hmm,
economic collapse,
mm-hmm.
but it didn't happen right away. It actually took about 8 to 12 months before we started seeing things really start impacting, right? So you don't typically see this, oh, as soon as this stuff starts, everything spikes. It really takes time because people are generally hopeful and resilient, and they think they're going to find a way through it. But as months pass, right, you
Yeah.
see that starts wearing down. So the sooner that we get back on our feet, the sooner the economy recovers, the more support we give folks, the less the impact will be. You prolong those things, there'll be a bigger impact.
Good information. And I like the way that you brought up how we went through this previous recession and what happened. And maybe we can use some of that information and the trends that happened then to help us to be better prepared about what's going on now. I just want to take a moment to thank everybody who's out there on Facebook Live who has joined us. If you have any questions you would like to ask Dr. Andrews, please shoot it out and we'll make sure that we get those questions to him. I want to take a little bit of a shift, Dr. Andrews, especially since this is about mental health professionals. If you don't mind, can you please address the vicarious trauma, the secondary trauma that mental health professionals might experience during this time, right? We're helping our clients get through this. We're helping other mental health professionals get through this. We're helping doctors and nurses. We're being a support to them and the trauma that they're experiencing. How might the vicarious trauma have impact on the mental health professional?
Yeah. So I think it's really important when we talk about burnout, we talk about vicarious trauma, we talk about compassion fatigue. These they're connected concepts, but they're actually very, very different, right? So when we talk about those things, it is likely that particularly healthcare professionals that are working long hours, that are grinding through this, there's a real disconnect right now. For instance, there's very different experiences that people are having as they go through this COVID crisis. Some people are fairly protected right now. Their income is good, their work demands are low, and they're huddled down with families in secure environments, and they're not worried about food or shelter or any of those things. And there might be some benefit from that. People are spending more time together. There's more social connection, right?
Mm-hmm.
There are, at the same time, there are many folks who are working, and a lot of healthcare professionals are actually self-segregating because they don't want to expose their families. So not only are they working really long hours, some of them are taking pay cuts while they're working.
Wow.
And they're also not staying with their family because they're worried about exposing their family. That definitely can lead to burnout, right? Where you're not getting enough time, you're not able to use your coping mechanisms, you're not around people that rejuvenate you, you're not getting your family time. That can definitely lead to burnout. Vicarious trauma is when we get exposed to something, particularly visually, right? That is really traumatic for us. So a crisis line in New York City did an analysis for months over staff handling crisis calls. They didn't find so much vicarious trauma, and the reason for this is because we're rarely getting visually exposed to really intense images, right?
Okay.
And so now if you're on the phone with somebody when something really bad happens, and we see this with 911 dispatchers, we see this with our own crisis counselor. So if they're on the phone with something really traumatic happens, that can often lead to vicarious trauma, right?
That's right.
It can, but vicarious trauma is really unusual in healthcare professionals. It's rarer unless they're working with people who are reporting really intense experiences of physical violence and that sort of thing, or they're getting exposed to visual information around those crises. What's more common is this idea of compassion fatigue,
Yeah.
and compassion fatigue, when we differentiate, vicarious trauma is when people are exposed to traumatic events, either hearing someone tell a story or seeing something indirectly, right? They weren't actually the person that experienced it, but they saw it or saw video of it or were told about it. And those folks literally have symptoms of post-traumatic stress disorder. They literally become hypervigilant. They may have trouble sleeping. They may ruminate or have flashbacks, right? So that's vicarious trauma. What's more common in healthcare providers is compassion fatigue. And what's different about compassion fatigue is when someone is involved in working with folks on an ongoing basis where the outcome is really tough, or you're not getting a lot of success, or the people you're working with are really struggling and you're having a hard time helping them get better. So you're dealing with a really difficult situation and you're doing that all day, every day.
Yes.
And one of the things that happens with compassion fatigue is that literally the person's self-concept of themselves as a healer gets altered, right? So when you're working with people in intense crisis every day who are talking about suicide every day, or talking about, I don't have a place to live, I don't have food to eat, I don't have money, I can't get work, how am I going to solve this? And you're getting one case like that after another, and you're doing the best you can, but you're not solving these big systemic issues. That can lead to compassion fatigue, where you no longer think that you're good at your job, right? That you're a good healer or a competent healer.
Yeah.
What's really key about compassion fatigue is how we differentiate burnout from compassion fatigue is that burnout typically is things that affect you specifically at work, how you are at work. Compassion fatigue is when it leaks out and it's also impacting you at home, right?
Yes.
When this ongoing caseload that's just wearing you down and changing the way you feel about yourself. Now when you're getting home, you're not connecting with your family. You're not able to relax. You're not able to do the things that you enjoy. You're more irritable. It's impacting you at work and outside of work, right?
Yeah.
That is something I think we're more likely to see as this progresses. Obviously, there'll be some vicarious trauma based on the types of context that people have, but compassion fatigue is probably a bigger issue, and something that healthcare providers are more likely to experience. We're certainly seeing it with our healthcare providers. Imagine they're used to treating people and knowing how to fix or solve the situation, and COVID's completely new. We don't even have really good treatments for COVID.
That's right.
And so, although we're getting better at it, doctors and nurses are not used to losing patients like that. They're not used to having to hard time getting symptoms under control because it's so new.
Yeah.
It's not that these doctors and nurses and support staff and respiratory therapists aren't competent. They're incredibly competent, but they're faced with a completely new condition that we don't know that much about.
Yes.
And so that sense of I want to be helpful and I want to save people, when you're not being as helpful as you were with the disorders that we understand a lot better, that can impact your view of yourself as a healer, as a caregiver. And that can definitely lead to compassion fatigue.
Yeah, I'm so grateful for your knowledge and that you are able to tell us the difference between vicarious trauma, compassion fatigue, and burnout. And you also included information on how to tell when we reach that point and when we need additional help as mental health providers. Dr. Andrews, I do have a question from Facebook. Thank you for submitting your questions. Dr. Andrews, can you speak on the trending rates of suicide in religious groups, specifically pastors?
So that's a really important question. There isn't a whole lot of research about this, and there's a lot of things that are at odds. For instance, we actually find that the suicide rate is lower in those that are highly religious and those that attend church services on a regular basis. In fact, being connected to a faith group tends to be incredibly protective of suicide. And the more rigorous, the more structured and more intense that membership is, the lower the suicide rate is. In fact, there are some religious groups that have incredibly low suicide rates, right?
Wow.
At the same time, we do see that pastors can have an increased risk of suicide. One of the reasons for this is that the demands on our clergy in our current environment is incredibly intense.
Yes.
Particularly new clergy, they have their own idea of what it's going to be like to pastor a flock and be that spiritual support. And then it turns out when they get us, and they get also, if folks don't know this, clergy in many churches, like the Lutheran synagogue, they get moved around a lot. They don't stay in the congregation, right? They're 2 years here, they're 2 years there. So their lives are constantly getting uprooted. So there's a lot of variability from church to church and faith to faith. So we're talking in some pretty big generalities. But what we tend to see is that because of the nature of the work they're doing, and people that go into pastoral care tend to be people that are they're healers, they're givers. They tend to put other people's needs before their own, and they tend to be very empathetic. Now you're going to hear me something. If you mental health professionals aren't aware of this, I'm going to blow your mind. Empathy is horrible. It's a horrible, horrible, horrible thing, right? In fact, there's really good research about how bad empathy is. There's a great book by a Yale social psychologist, Paul Bloom, Against Empathy. And he really makes some clear distinctions between empathy and compassion. Empathy is when we feel things that other people are feeling. It's emotional. Compassion is when we're intellectually, cognitively aware that people are struggling and are able to provide care, but also maintain a distance from them so that we can be effective in helping them and protect ourselves. There's lots of good data on why empathy is absolutely horrible, and pastors tend to be really empathetic. So if you are young, you're getting moved around a lot, you're dealing with a flock with a lot of stress and a lot of pain in their lives, and you're trying to help them and you don't have a lot of source and support, you may start feeling that compassion fatigue, right? And also imagine if your faith is really strong and here you're doing all this work and people aren't getting, you don't feel like people are getting better, you don't feel like you're being helpful. You may have a crisis of faith wrapped up in that. You know, where is my faith? Where is my God and all this? So these folks can be incredibly vulnerable, and their support networks are often incredibly weak because they're either new or they're getting moved around a lot. And they have high visibility, right? So they have to be seen as all together and strong, and it's really hard for them to be vulnerable, and there's a tremendous barriers to getting help for those folks. So those are all things that can contribute to someone in pastoral care having increased risk of suicide. And again, that's it's something that we see in some places and not in others, but it's real. And I get really, really concerned, particularly about new clergy who don't have a lot of support dealing with a new flock. That can be incredibly stressful. And your middle-aged clergy who might be going through a life transition, a divorce or job displacement, those types of things. So that these transition periods, those can be real risk periods as well.
Yeah. And COVID-19 kind of exacerbates the situation because this is, again, something that pastors have never dealt with before, just like the doctors and the nurses. So along with all of the regular stuff that can get after pastors and pastoral care, now we have this pandemic that has never been experienced before in the history of the world. And that's adding on top of whatever issues they may have been experiencing, or the lack of resources, or the lack of care. Don't you think that kind of makes it worse with the
It
COVID-19?
absolutely, oh, absolutely, Kenya. It makes it a lot worse. One of the things that we do, unfortunately, to a lot of our professionals is we expect them to be experts.
Mm-hmm.
And here's the hard part. Nobody, other than a few epidemiologists, are experts on pandemics, and very few people are experts in terms of behavioral health or pastoral care and handling a pandemic. There's no such thing as expertise in these things. What we don't make it okay for our professionals to be is an expert in knowing what they know and what they don't know, right? One of the areas I really encourage healthcare professionals to develop expertise on is being an expert on what you don't know and when you need consultation and guidance and when you're uncertain.
That's
It is
good.
incredibly important.
Good.
You cannot be an expert in all these things. And I know, here's how I know when I'm talking with a real expert. When you ask them a question, they say, I don't really know the answer to that.
Mm.
That tells me that that person has really good expertise, because if you're talking to somebody and they know everything and all know the answers to all this stuff, that's usually a sign they're insecure and they're trying to act like they know things when they don't know those things. And that puts a tremendous amount of pressure on people. So one of the freeing things about COVID and the pandemic is nobody's an expert in this. Nobody's an expert in this. And so you get to develop your own expertise, and you can also acknowledge, I'm not an expert in this, doing the best I can. Here's some things we're going to try. Let's see if that works. And if that doesn't work, we're going to try something else. It's really about being able to embrace those things that we do understand well and those things that we clearly don't understand well, and knowing that it's okay to say, I don't know what the exact answer is, but let's try this, or here's some things we can try to see if they help.
Oh, that's great. That's good stuff, Dr. Andrews. I appreciate what you just said. It's okay not to know everything. I need to be reminded of that. Our mental health professionals need to be reminded of that. We appreciate that. We probably have time for one more question from Facebook Live. So if you're out there and you're watching, go ahead and submit a question and we'll ask Dr. Andrews again. Something that I want to ask you, Dr. Andrews. You already talked to us about compassion fatigue, burnout, what that kind of looks like for the mental health professionals. Where do we go to get help? I remember when I was at a previous employer, I was having a really hard time in life, a really hard time with my clients, and I asked my supervisor, where do we go when we need help? I know where I send my clients. I know how to tell them where to go. I know how to tell them which hospital to go to or get them the help that they need. But where do we go when we need help as mental health professionals?
It's a really important question, Kenya. Most of us have access to employee assistance programs. So if you're working in a healthcare agency or if you're working in a behavioral health agency, find out about your EAP. EAPs are fantastic because they're typically 24/7.
Yeah.
The phones are typically answered by trained clinicians. And not only can they provide support telephonically right in the moment to take care of you immediately, but typically EAPs are really good at getting you in for appointments in the next couple of days so they can get you in and seen quickly. They're typically time limited, so 3 to 6 sessions, depending on your employee assistance program, but it's a good place to get started.
Yeah.
It's incredibly important that we as clinicians model getting therapy. There is a great book. I encourage every clinician out there to read this book. Maybe You Should Talk to Somebody, I think the book is called, and it's written by a therapist who talks about her own experience. She's dealing with a difficult client. She's dealing with some difficult relationship issues, and she goes and she sees a therapist. And the book really just is an autobiographical account of how she was seeing a therapist while providing therapy, and it's so incredibly powerful. At times it's hysterical, at other times it's deeply moving. You cannot get through that book without crying. It's incredibly powerful. And she really models well how really good therapists get therapy. And there's a lot of good data that therapists that get therapy are better therapists than therapists that don't get therapy. So if you're a clinician out there and you're thinking, maybe I should talk to somebody, here's my answer. Yes, do it. You'll love it. It's really helpful and it'll make you a better therapist.
I agree with that, Dr. Andrews. Thank you so much. I'm going to check and see if we have any more questions from Facebook Live. Doesn't look like it, and our time is about up for today. Thank you, Dr. Andrews, so much for the wealth of information that you provided today. I am sure that mental health professionals out there who had a chance to watch this and be a part of the Facebook Live today received some insight, some information that they did not know about. Will you tell us the name of that book one more time?
Yeah, I think it's called You Should Talk to Somebody.
You should talk to somebody.
Oh my God, it's such an amazing read. Anybody who reads it, you will love it. The author, she's incredibly smart. Her writing style is so engaging. She's so vulnerable and honest. And the book is just for mental health professionals. It's a must read.
Oh, that's great. That's great. We'll put that later on in the comments later on. So anyone who comes after the live is over and needs the information about that book, we'll make sure that we get it out and make it public for you. Thank you again, Dr. Andrews. I hope that this is one of many conversations that we'll continue to have about mental health professionals, because I believe it should be an ongoing conversation and not a one-time event. I believe that after people watch this live, they're going to develop more questions, and we'll have to come back later and make sure that we address those conversations and really make it a part of a support network where people can come to BHR and really connect, especially as mental health professionals. I want to take this time to thank Pat Coleman, our CEO of Behavioral Health Response, for allowing us to have this opportunity to talk to mental health professionals. I want to thank our manager, Holly Nemec, for giving us this platform and giving us the okay for the Trauma Informed Care team to come and talk to you weekly. I want to thank my team members for helping us out today, Tara Stevens and Jesse Brown. We can't do it without each other. And Lisa Flamion. Everybody's been doing such a great job with getting this information out there to the public. And maybe you have some suggestions on what you want to see, on what you want us to talk about here at Behavioral Health Response. I want to thank all of our new likes and our new people who have become engaged with Behavioral Health Response. Thank you so much for being a part of our community. And we're just asking you to keep looking out there. There's more good stuff coming. This is just the beginning. Thank you for your time today. Thank you again, Dr. Andrews.
Thank you.
Have a good day, everybody.